Before we get started, the mission statement of Scrubs. Scrubs is a student-derived initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody, and we involve ourselves in a variety of subcommittees that work with these resources for students by students, trying to offer a perspective of a student who's gone through this material ourselves. If this is something that aligns with your own goals, we are always welcoming members, and we hope you join the team. As a brief disclaimer, these resources are made by students, not by faculty, so there is a possibility for errors, even though we do try to mitigate this as much as possible. If there's ever a contradiction with the coursework and what's presented in your course, please go by your primary course documents. Additionally, this is a supplemental resource and not a primary resource for your studies. This is not a replacement for instruction by the Brody faculty, but rather as a supplement. So please use these resources as a supplement and not your primary source for material. With that, let's go ahead and get into the joints of the lower limb. Starting out with the hip joint, we want to point out a couple of ligaments and structures that you need to know. The first thing that we want to point out is that the head of the femur is articulated with the acetabulum of the pelvis. And the acetabulum is this structure located here. And you notice that as we come around, it's actually incomplete in the inferior region. And the inferior region of the acetabulum that is incomplete is called the acetabular notch. Now, the acetabular notch has a ligament that goes from either side, and this labeled as number 7 in this image. The ligament that transverses the acetabular notch is going to be called the transverse acetabular ligament. Okay, so transverse acetabular ligament kind of joining the borders of the acetabular notch. Okay, and then with that, I also want to point out that just like in the shoulder joint, there is a ring of tissue that surrounds the synovium or the joint capsule, labeled as number 2 here, and this is going to be the labrum. Okay, so specifically the acetabular labrum, located here, number 2. All right, with that, we want to go ahead and start identifying some of the ligaments of the hip joint. These are ligaments that are going to provide structural support and as well as limiting different motions of the hip to make sure we're not getting hyperextension or abduction, whatever the case may be. So let's start with the iliofemoral ligament. We'll see this on another slide as well. The iliofemoral ligament is a Y-shaped ligament. It's located at the anterior aspect of the hip. Again, we'll see this better in the next slide. The attachment points are the anterior-inferior iliac spine and the intertrochanteric line. Remember, the intertrochanteric line is on the anterior aspect of the femur. The pubofemoral ligament, it's going to attach at the superior pubic ramus and in the inferior region of the intertrochanteric line. So it's going to be directly below the iliofemoral ligament. Lastly, we have the ischiofemoral ligament. These are our 3 main ligaments. This is going to arise from the ischial body and insert into the greater trochanter. This one's actually located a little bit posteriorly to our other ligaments. Now, all of these ligaments together are going to prevent hyperextension. Okay, so all these ligaments together are preventing hyperextension. And we also have a couple other ligaments. The ligament of the head of the to the head of the femur, that's going to be located as number 4 here. It actually comes through the acetabulum and goes to the head of the femur. Okay, and within that we have the artery of the ligament of the head of the femur. All right, so this is a ligament of the head of the femur here, number 4, and number 8 you can actually see an artery that runs through that. Lastly, we already talked about the transverse acetabular ligament, but that is located number 7 here. It's going to transverse across the acetabular notch, because remember the acetabulum is not completely closed. We do have a little notch here that is bordered by the transverse acetabular ligament. With that, let's go to a view that we can see these ligaments in a little bit more detail. So here we go with the hip joint, kind of seeing some more of these structures. What we're going to have here is the iliofemoral ligament is located right here. Remember, we said that it was a Y shape with the stem arising from the anterior-inferior iliac spine, which is located right here, and then it's going into the intertrochanteric line, which we can see here, the superior and inferior components of that. Now, just below that, we have the pubofemoral ligament. Great thing, pubo for the pubis, where it arises, inserting into the femur, coming down right through here. So this is our pubofemoral ligament. And then back in the back, posteriorly, where we can't really see it, that's going to be our ischiofemoral ligament. And you can imagine it's going to go from the ischium all the way to the femur. So specifically the ischial body, located kind of posteriorly to where this marker is, and then inserting into the greater trochanter here, we can see a little bit of that ligament located right there. And these all reinforce the hip joint and primarily are preventing hyperextension of the joint. Also important to know, the pubofemoral ligament is going to prevent over abduction, so abduction, so pulling too far away from the hip joint. And that makes sense, because if we imagine taking the inferior portion of the femur and bringing it out, abducting, the head of the femur starts to come down. And it's going to rest right up against the pubofemoral ligament, so it's going to be preventing that action from going too far. So that's over abduction with a pubofemoral ligament. Now, before we move on to another joint, we do want to talk about some of the vasculature. I know this is a little bit of review from some of our other videos, but it's important that we understand the cruciate anastomosis supplying blood supply to the head of the femur. So the cruciate anastomosis from your course pack is going to be made up of these components: the medial circumflex femoral artery, lateral circumflex femoral artery, the obturator artery, inferior gluteal artery, and an acetabular branch along, and have obturator artery up here twice. Just ignore the second one. Now I want to show it here, this image. Right here we have the profundus femoral artery. And remember, the profundus femoral artery is giving off a lateral circumflex femoral artery that has a ascending branch, a transverse branch, and a descending branch. It's really this ascending branch that is supplying blood supply to the head of the femur. Right here, number 4, this is the artery of the ligament of the femur, or the artery of the ligament of the head of the femur, which we saw in the previous image, kind of supplying this region here. And then the main blood supply is coming from the medial circumflex femoral artery. Now, again, not shown in this image, we do need to keep up with the fact that there is a component of the obturator artery and the inferior gluteal artery helping to supply this region as well. And they all together form the cruciate anastomosis. Moving into the knee joint has a couple of ligaments. They're relatively straightforward. We're going to have 2 collateral ligaments on the side and then 2 cruciate ligaments, along with 2 menisci. So let's start with the ACL, which I know many of you have heard about. This is the anterior cruciate ligament. So it's going to start up here on the anterior medial aspect of the tibia. So remember, we know this is lateral because we see the fibula here, but it's going to start anterior medial and it's going to run posterior lateral. And you're going to see this if you're looking at the knee joint. It's going to be the first ligament you see. Then we have a posterior cruciate ligament, which is starting posterior medially and coming anterior laterally. Okay, inserting right there into the intertrochanteric region. Now, we have tibial plateaus on the top of the tibia, and on top of each one of those plateaus, we have a meniscus. So on the lateral side, there's a lateral meniscus located right here. And on the medial side, there's a medial meniscus. This is going to help with the articulation between the femur and the tibia. And then on either side of our joint capsule, we're going to have collateral ligaments. This is going to be on the lateral side, our lateral collateral ligament, and on our medial side, our medial collateral ligament. Now, I do want to point out here, you can see that the medial collateral ligament and the medial meniscus are pretty close together, and they're actually going to be firmly attached anatomically. Whereas there's a little bit of space here between the LCL, or the lateral collateral ligament, and the lateral meniscus. And this is because we have a muscle called the popliteus muscle that is going to actually be separating these structures anatomically. And we're going to see why that is important in the clinical correlations. But the big thing to know is that when you often tear the MCL, there's a good chance you tore the medial meniscus as well because they're so closely attached. Whereas the popliteus oftentimes separates the LCL and meniscus, so you often don't tear those at the same time in different sports injuries. Now, I do want to point out with the ACL, when you are extending the knee, so when you're extending the knee, you are actually tensing the ACL, and it's going to prevent anterior displacement. When we're talking about displacement, we're talking about the joint or the bone distal to the joint. So anterior displacement would be bringing the tibia anterior to the femur. PCL is going to be tense when there's flexion, so when I'm bringing my heel towards my gluteus muscles, and this is going to prevent posterior displacement. So once again, displacement is referring to the distal bone. So posterior displacement would take the tibia and push it back through the screen behind the femur. Now, continuing to move down through the rest of our anatomy, we have the ankle joint. The ankle joint is important to remember. It's a hinge joint. So there are some joints in the foot that allow for eversion, inversion, but the ankle joint should not be allowing for that motion. Specifically, a hinge joint that only allows dorsal and plantar flexion. So the 2 major regions that you need to know are on the medial aspect of the ankle and the lateral aspect of the ankle. The medial aspect of the ankle has the deltoid ligament, which is made up of 4 total ligaments. So it's the deltoid complex made up of 4 ligaments. These all have a common start. They all say tibio something. And so it's going to be tibio wherever the ligament's going. So you have the anterior tibio-talar ligament. So this goes from the tibia to the talus, which is the bone directly underneath the tibia. So we can follow that ligament here. So tibio tibio-talar ligament, anterior tibio-talar ligament. We have a tibio-navicular ligament, which goes from the tibia to the navicular bone. We have a tibio-calcaneal ligament going from the tibia to the calcaneus, which is the heel bone back in here. And then we have a posterior tibio-talar ligament. It's right here, tibia talus. These are going to be the ligaments of the deltoid ligament, which is comparative to our lateral foot, is going to be much stronger of a ligament. Now, going to the lateral aspect of our ankle, we're going to have, in this case, as opposed to tibio something, these are all going to start with talofibular, or endinfibular. So their ending is fibular, whereas here we were thinking about the prefix being tibio. Over here, we're thinking about the suffix of fibular. So we have an anterior talofibular ligament, a posterior talofibular ligament, and we also have a calcaneofibular ligament. So just remember, when you're on the medial side of the foot, looking at the deltoid ligaments, everything's going to start with tibio. And then if you're on the lateral aspect, looking where the fibula is, all of the suffixes should be fibular. And then you just need to know what bone is the ligament arising from. It's a really great thing about ligaments. They always say where they start, say where they're going. Now, continuing to talk about the foot joints specifically. So the foot joints are separate from the ankle joints. The two joints of the foot that really allow motion are the subtalar joint, located right here, and the transverse tarsal joint, located between the tarsal bones. So the subtalar joint is between the talus and calcaneus, and transverse tarsal is directly in front of that. These joints are going to be the joints that allow for the inversion and eversion around the ankle. Around the foot. And the main thing I want to point out here as well is that we have a couple different arches of the foot. We have some longitudinal arches, and we have a transverse arch. The most important part is that this longitudinal arch has a medial aspect and a lateral aspect. The medial aspect is a little bit more pronounced, so the arch is a little bit greater on the medial aspect. Now, it is important that we have this arch because this is going to allow force to be transmitted from our metatarsals to our calcaneus, and that should be the two regions that have the most pressure of our foot. You might hear some people talk about having flat feet. That means that these arches aren't supported as well, and it causes a distribution that is not normally present anatomically. So the pressure on the feet is different, which causes a sequela of different events. The one ligament that I do want to point out over here in the foot is the calcaneonavicular ligament. So just like it says, it goes from the calcaneus, goes to the navicular bone. We can follow it up here. And this is going to be called the Sprain ligament. Okay, so calcaneonavicular ligament, also known as a Sprain ligament in your course pack. Now, throwing in some clinical anatomy, and then we'll finish this video on up. So first thing we will point out is hip fractures. There are a couple of different kinds of things when we say hip fracture. Oftentimes a hip fracture is referring to a fracture of the femoral neck. So it's important when we have a femoral neck fracture, remember that we have a blood supply that's supplying the head of the femur. And that is due to the cruciate anastomosis. Well, right here in this region is where we have the medial circumflex femoral artery coming around. So it is oftentimes damaged in this femoral neck fracture. And if that vessel supply is damaged, because the medial circumflex femoral is the primary vessel that supplies the femoral head, there's oftentimes not enough blood supply to sustain the tissue here, and you get avascular necrosis, meaning that there's no blood supply and the tissue starts to die. So be concerned for avascular necrosis when you have a femoral head or femoral neck fracture, because the medial circumflex femoral artery not supplying the femoral head. Next, we want to talk about the difference between genu valgum and genu varum. These can be congenital abnormalities. These can also be developmental due to secondary things like osteoarthritis or different injuries to our ligaments. But the way that I think about this is genu valgum, with the gum makes your knees stick together. So this is going to be also another term for this as knock knees. So valgus stress is also bringing the knee medially. Okay, so the knees coming together. So valgum. And then think about holding a bottle of rum between your legs for genu varum. So we're going to talk a little bit later about testing the knee joint. There's a way that you can test varus stress. So varus, like varum, is pushing a force from medial to lateral at the knee. And there's valgus stress, which is a force coming from lateral to medial, pushing the knees together. So speaking of testing of the knee, the ligaments that we talked about were the ACL, the PCL, and then the medial and lateral collateral ligaments. And this is really the way that we test each of these. The ACL and PCL can be tested via the drawer test. That's when we bring the knee up, and in this region we have the femur coming up, and then we have the tibia below. We should have the ACL and PCL located within the joint, and that should be keeping my tibia from being able to be displaced anteriorly and displaced posteriorly. So what I'll do is I put my thumbs on the tibial plateau, and I'm going to pull the tibia anteriorly, see if I can move it towards me. If I can do that and I don't get a good catch, that is an indication that the ACL has been torn. I'm going to do the same thing and push backwards. If I can move the tibia posteriorly through the joint without getting a catch from the PCL, that tells me that the PCL has been damaged. So this is the anterior and posterior drawer test. Another way to test the joints of the knee is the valgus and varus stress test. With the varus stress test, just like we said earlier, varus, like varum, it's a force that's going from medial to lateral. Okay, so what we do is we put our hands on the joint line on the medial aspect of the knee, and we're pushing laterally while we bring the foot medially. And this is going to stress this lateral collateral ligament. So if I can do this without any kind of resistance, this is an indication that the lateral collateral ligament has been injured. Same thing with the valgus stress test. In this case, we're pushing from the lateral aspect of the knee towards the medial aspect of the knee, and while we're bringing the foot out. So as opposed to testing the LCL, which will be located here, we're now testing the MCL, our medial collateral ligament. One other thing that you'll see pretty commonly is the clinical picture of the unhappy triad. The unhappy triad is damage to each of these three structures that are often torn together. The anterior cruciate ligament, or ACL, which is located here, number 1. Remember, it starts anterior medially, runs posterior laterally. The medial meniscus, located here, number 2, and the ligament is closely associated with the medial collateral ligament, number 3 here. So this injury is often, most commonly occurs to a blow to the posterior lateral knee, so in the direction of this area here, direction of the force, when the knee is planted, or the knee is planted and you have a fixed foot. Another way this can happen is due to severe rotation, like this skier here. But you'll often see this in a clinical vignette presented as a football player being hit from behind, forcing the tibia anterior and medially. Last thing we're going to touch on is ankle sprains. There are two categories of ankle sprains that we commonly talk about: low ankle sprains and high ankle sprains. Low ankle sprains are often due to the ligaments down here at the inferior aspect of the ankle. High ankle sprains often refer to a little bit higher up, which isn't really covered in this course. So with low ankle sprains, the most common ligament that is injured in a low ankle sprain is the anterior talofibular ligament. Okay, it's important to know the anterior talofibular is the most common injury in a low ankle sprain, and that's because this is on the lateral aspect of the foot. Remember, the ligaments on the lateral aspect of our foot are not as strong as the ligaments on the medial aspect of our foot, which is our deltoid complex. So the lateral ligaments, you can actually do this on your feet. Try to take your foot and invert it, so bringing your sole medially. You can do that pretty easily, right? If I try to do the opposite and do eversion, there's a lot of restriction. So oftentimes what happens is someone will step, and they'll have inversion of the foot, which will tear one of these ligaments, most often the anterior talofibular ligament. So ankle sprain, high suspicion should be an inversion injury, specifically injuring the anterior talofibular ligament. And that'll bring us an end to this video.